and other interventions for treatment might be processes as well. What we did first was look at administrative data, and the most comprehensive administrative data currently resides in the Medicaid data, where because the state is the payer, we have access to Medicaid claims and encounters, and there are definitive codes in those data that reflect depression screening and also the result of the screening. These G codes that are CPT codes that are housed in those data include whether the patient was screened, and if so, was there a positive result, and actually gets into treatment as well, because there has to be an identified follow-up plan for the first code, the G48431, and then the other code represents patients who had a screening for clinical depression but had a negative result, and so a follow-up plan wasn't needed. One of the limitations of those codes, which are listed down below, is that screening by itself is not captured. So you may be missing patients who were eligible but did not have a screen, although the sum of those two should represent the proportion that were screened. So that's somewhat of a limitation. There's also some limitation on the validity of use of these codes. We actually did some studies around use of these codes. They're not commonly used yet, so they can underrepresent what screenings actually taken place for Medicaid members with maternal depression. And then there's another code that's even more general, that is an older code that was used up through November 2016 in Medicaid, that just looks at health risk assessments, not really too specific. Some of the other limitations include that those codes can be used for other populations, so you really have to identify your eligibles. It's only reimbursed currently for postpartum maternal depression, and that's payable in Medicaid to either a maternal or a child provider, so it captures those women who are screened in the pediatrician's office, for example, the mothers who are screened at a pediatric visit, where there might be more capture than trying to get women to have access to postpartum visit. So you might be missing antenatal depression through use of these codes as well. We know that it's underrepresented. We got very low rates when it was calculated using these codes for last year's data. And that varies a lot from other data sources like the Pram Survey, which asks women directly about being asked about depressive symptoms. These screens should be done using a standardized tool, but that's not always the case if you look at records when this is reported. And then the other issue is that the positive screen can vary across tools and actually can be somewhat open to interpretation within a specific tool like PHQ-9. Next slide. Of course, medical record data is really the most robust if you can get to it, but it's somewhat difficult to extract screening and result data from even electronic medical records. Some things that we found that are currently in place include one of the qualified entities, the Bronx Rio, that collects electronic health data, is using natural language processing, so they can actually extract these data from notes in the chart without having to do manual chart review. So they're looking for PHQ-2 and PHQ-9 screening tools. SNOMED codes are something that I'm in the middle of trying to do more research on. That's a national standard language for health, electronic health information. The National Library of Medicine put out several years ago, I think 2013. It's supposed to be universally used, and it used to be part of meaningful use nationally. In discussion with some of our measurement experts here in the department, it seems like they're infrequently used, although they are doing a few pilot studies looking at these codes for different entities like diabetes. But there are some pretty good codes that are included in measures nationally for depression screening and result negative depression, positive depression screening, and for depression diagnoses as well. They're clinical diagnostic data for the most part, although they do include screening. And so some of the limitations of using the electronic chart data is, of course, that it's variable across these qualified entities, RIOs, on how they collect this information. The Bronx kind of went out and did this on their own, apparently. So they're ahead of the game, but it's not universal. And EHRs themselves have a lot of differences in how these data are recorded and how it can be extracted. So there's some limitations there. Next slide. Reported registries are great. Of course, they're limited because they're only a specific population who are participating usually in a pilot or, a certain program that data are reported directly from practitioners. In the first 1,000 days pilot, that the state is conducting several projects for early childhood. One of them is a centering pregnancy, group pregnancy model. And in that pilot, we are setting up a system to collect antenatal and postpartum depression that will be reported by those practices who are participating in the centering pregnancy pilot. So that's going to start in June, and we'll have pretty good data in that regard for those specific practices. The Maternal and Infant Community Health Collaborative is looking at community services for eligible women that includes a care coordination form in which depression is identified. Community health workers screen and refer for maternal depression to community services. So that's another source of data for those areas that are conducting those collaboratives. I'm sorry, I lost my place. And then there's home visiting programs. The maternal, infant, and early childhood home visiting programs are reporting prenatal and postpartum depression screening, positive screening, and referral to treatment. So that's a pretty complete data set for those women who are receiving that service. WIC programs are reporting depression screening using a 2-item PHQ-2 screening tool. It is electronically reported, and what's been noticed by individuals who are responsible for collecting that data, and I think Amy's just say this is on the phone from the Division of Family Health that is collecting these data. They note that the positive screen rate is very low, although the screening rate overall is very high, which is great for those women participating in WIC. And then the Office of Mental Health is conducting a collaborative care model, integrated behavioral health care and primary care, the impact model that is reported into a population health registry in the Office of Mental Health that collects data regarding screening with PHQ-9 and PHQ-2, PHQ-9, and also collects response to treatment with PHQ-9 and remission, actually. PHQ score less than 5 for remission and less than 9 for response. Limitations of all these registry data include in OMH model that the EHRs, again, just indicate whether someone was screened or not screened. It's actually difficult to pull out the results of that. Next slide, please. Finally, there's survey data looking at processes, and that's the pregnancy risk assessment monitoring system. There's actually a dashboard in New York State, and then a specific Pram's data site as well. These are survey questions conducted on a stratified random sample of women with a live birth using vital record data to identify them, and you can query those data by New York City and rest of state, Medicaid or not, and some other parameters, although I did not see race and ethnicity data in there. And the query is fairly broad for screening. Mainly, did your provider ask about symptoms of depression at a postpartum visit? And then the percent of women reporting that they did is reported in the reports that are in the dashboard on the website for Office of Family Health. The diagnoses are also collected, particularly in the 2016 that's ongoing data collection right now. There are a lot of questions around depression preconception, whether there was depression diagnosed during pregnancy, and a lot more prevalence type information, it looks like, in the most recent survey that I did not see the results for yet. So those are the processes. And then in the next slide and next couple of slides, we're going to talk about just some treatment and outcome data, which, you know, I think is of interest to everyone, and we're trying to move more towards these outcome data. But in Medicaid claims, aside from the follow-up documentation that we talked about with one of the screening codes that we collect in Medicaid, we also have access to identifying behavioral health visits for those women who are on Medicaid, including during pregnancy, after pregnancy. We have access to pharmacy data that we can look at antidepressant therapy. And then looking at Sparks, both Medicaid and Sparks data for the broader population of not just Medicaid, but all payer, we can look at discharges from emergency department and inpatient stays that are related to depression, self-harm, and how those relate to a pregnancy episode. So that's a fairly good data source for outcome data. And then, of course, medical records in the electronic medical record system with all their limitations that we noted before. They should include documentation of referrals, treatment, antidepressants, and things like that that could be extracted. And finally, in the registry data, as I mentioned, not very articulately, but impact data does include PHQ-9 response and remission scores, or at least is moving towards that, having those data available. Next slide. Future state, things should get better. Next slide. There's an all-payer database that's being developed in New York State that's going to have claims and encounter data from all payers. Currently, Medicaid is in there, and some commercial is also included. Medicare is not yet in there, I don't think. And then there's, of course, self-pay would not be in there, but it'll be more complete than just the Medicaid data. And it's also able to be linked to vital records data and Sparks data for those inpatient and ED encounters, so that you can get a pretty good overview of a patient's course. This is not going to be completed within the scope of this project, but ultimately will be a great way to monitor someone over the course of an episode. The first 1,000 days project data, we talked about a little bit about the centering model, where we're going to be collecting depression screening, but there's also several other projects. There are 10 altogether, and another 3 of them in particular are looking at data systems for cross-sector referrals. We spoke to the people who are working on that, and I think we have Kendra on the phone from Office of Health Insurance Programs, but the individuals who are working on this in particular are not yet looking at maternal risk, so they have pilot projects on sharing data for referrals cross-sector, but haven't addressed maternal depression. But that's a possibility going forward once those pilots are underway. They are looking at dyadic therapy for the maternal mother-child dyad, and we can look forward to seeing how those projects pan out. They're fairly early getting started, this one and the next one, which is the home visitation pilot project, where there's a possibility of data collection in that arena as well. Next slide. And then just this is the last thing, just a couple of measures, next slide, that are available currently that are being reported. Medicaid postpartum depression and follow-up reported from those codes we talked about, which reflects the number of postpartum women who are enrolled in Medicaid who are screened for depression during postpartum care up to 1 year after delivery. And then the denominator is the number of women enrolled in Medicaid who are receiving postpartum care. So you'll be missing women who didn't make it to a postpartum visit, although now, you know, we have access to data reported by pediatricians as well. The rates for this aren't public yet, but they're quite low, and it probably reflects the data use of those codes being low rather than actual screening rates. It's promising going forward. A lot of the Medicaid value-based payment arrangements include screening for clinical depression and follow-up in the Medicaid redesign work. That reflects the number of patients screened for depression with a standardized tool and a follow-up plan documented with the denominator of everyone who had a visit with a primary care provider. This uses hybrid data, which means that they acknowledge that the claims are not reflective of the totality of screening, and it is supplemented with a review of medical records, so it's somewhat infeasible and unwieldy, burden intensive to collect this measure. In the VBP child core set of measures, the arrangement for children, there is a maternal postpartum depression screening rate that hasn't been implemented yet. It's a category 2, which means it's recommended, but hasn't been found to be feasible yet, that can use electronic health data and looks at the percent of children who turned 6 months of age who had documentation of a maternal depression screen for the mother. And then the Impact Collaborative, I don't have rates, but in their registry, apparently, OMH can correct me if I'm wrong, but it's the number of patients screened for depression with a PHQ-9, and then the number with a PHQ-9 less than 5 or in remission among those screened. And finally, the Pram survey I talked about, which reports the percent of women reporting that the healthcare provider asked them about depressive symptoms at a postpartum visit. And those rates are pretty high. So we were getting really low rates for the Medicaid data in the less than 10% type of range, which is probably not accurate. But in the Pram survey, we found about 76% of women acknowledged being asked about depression at postpartum visit. Next slide. I think that's just about the last one. And what's coming up, the HEDIS measure, which are reported by health plans annually in 2020 is going to include maternal depression screening using electronic health record data. That's actually going to stratify by women screened for depression during pregnancy and those screened for depression postpartum. So you'll get antenatal screening as well as postpartum screening. And that's the measure we're going to be using in the Centering Pregnancy Group Model of Care pilot program. I think the next slide is just, oh, I'm sorry, just a couple of policies that Lauren put together for us here. In Medicaid, a couple things just to note that women in Medicaid, actually members in Medicaid managed care can self-refer for mental health assessments without pre-authorization. That's in the managed care model contract. Maternal depression screening in fee-for-service, those 2 codes we showed you, is reimbursed in addition to just the visit claim and can be reimbursed up to 3 times for women during the first year of the infant's life. And it's an additional payment per visit of $15.60 for fee-for-service. Medicaid managed care plans can also reimburse over and above the rate they pay for the visit, but it depends on the plan what that additional payment will be. In that context, screening can be provided by both the mother's healthcare provider or the infant's, pediatrician, and that service can be part of a well-child visit, so it can be incorporated into when they take the baby for their well-child check. They can also screen the mother as part of the environmental risk for the child. Medicaid managed care plans have to provide mental health education to enrollees, so that's part of the benefit. And then the other thing that I think was mentioned by another state, maybe Pennsylvania, that psychotherapy coverage is paid for based on therapy intervals of 30, 45, and 60 minutes, but there's no distinct code that we could find for cognitive behavioral therapy or interpersonal therapy, so the type of therapy is difficult to ferret out. And then I think the next slide is just some discussion points, but I think Bridget's were probably more salient on what else you would like to see, what would be important for the workers on the ground to have understanding of and access to. And are we talking about, does the population need to be expanded? Are there data sources you're aware of that we haven't touched on? Other metrics you would like to see, including utilization or outcomes of women with maternal depression. We still need to talk about data sharing and how that works. And any other topics you'd want to bring up. But I'm open to questions as well at this time. So Bridget, I'll turn it back over to you.
Okay, so I am going to unmute people so we can have conversation. And I'll go back to that earlier slides. I really appreciate people bearing with us here on but I see we're mostly among friends, so so it's a good time to sort of have a right. Is anybody able to talk?
Yes, you've unmuted us.
Okay, we're unmuting. Okay.
It looks like some might still be muted.
All right. All right. So I'm going to go back to that that previous slide.
Got a couple.
Get where we had the questions. Okay. So I think one of the things that we wanted to accomplish today, or get people's input, is given the great wealth of information that Jean gave today, are there things that are missing or aspects of data that you think should be included? I think our idea is, how do we, as we're thinking moving this forward, how do we come up with the right information, the right data that becomes usable for people with programs, or to help better inform policy decisions? Are we capturing the right things? What is missing from this? And where do you think we should be putting an emphasis or building new things into looking at data? So any sort of comments? Anybody want to kick any of this off? Is anybody talk? Have I just not done this right?
No, it looks like people are unmuted, and there's some hands raised, Bridget.
Maybe
so
they're not.
I think some people are raising hands. I see Lolita Johnson, I think.
Hey, Bridget. This is Darcy.
Okay.
Can you hear me?
Okay, Darcy. Yep.
Hi. So I guess I'm not sure where we want the conversation to go, but when I'm hearing this presentation and looking at your questions, I think that looking at program level data where they are addressing depression, for instance, our implicit project that we have across the state, sharing those positive screening rates with the community and with moms, I think helps raise awareness about the problem. But then even simple things like sharing those billing codes. I've run across different providers or practices where they're not aware, or they're not screening, and they're not billing for those, and they're leaving the money on the table.
Okay, so one of your issues is you don't think providers are familiar with the coding properly, and probably better education around coding would be beneficial?
Yes.
Okay. And also, Darcy, I think you've talked about this before. You have at least one project that's gathering data at the local level.
Yeah, it's our implicit interconception care model, and we have 10 or so sites, practices across the state that are implementing it and tracking that data.
Okay. I think one of the things that might be useful, because I know you're doing a project and other people are doing projects, I wonder if at some point it might be useful to have a conversation just among programs that are collecting data at a local level to see if there is a uniformity about how that's being collected at the local level across the states, and whether or not there's ways to sort of standardize or at least understand how it's being collected at a local level and how usable or transferable that information is?
Yeah, this is Jean. I think that would be great. Was that Dorothy? I couldn't hear the name who just spoke, but I was wondering what data are being collected in the implicit interconception care model. Is it screening and diagnoses or just screening?
This is Darcy, and they're collecting data on the screening, and first they screen with the PHQ-2, and if that's positive, either the PHQ-9 or the Edinburgh, whichever is preferred.
Right.
And then they're tracking, I believe they're calling it behavior change, but it's subsequent well child visits, whether or not mom is still screening positive.
Okay, thank you.
Okay, so I see some people with their hands raised. Lalita, did you want to make a comment?
Yes, I do have a comment. Actually, I have a question first. Now, you talked about impact, like the impact collaboration. Is that in reference to the University of Penn impact model with the community health? It's a community health worker program, or was that a totally different impact collaboration?
Christine, I don't know if anybody from OMH is on that can address that, but it's an integration of behavioral health into primary care, the impact model, so that primary care providers are integrating with a behavioral health provider and I think they also provide screening and things in the primary care site, but I don't know if anybody from OMH can address that. Amy Jones is the one we spoke with.
Yeah, we can definitely look for more information on that.
Yeah.
And share that with you, Lalita. We can connect you with somebody.
Okay.
Next, Eva.
Can I just say that Wilma Alvarado was asking if couldn't quite hear the question, but the question was about the impact model and its etiology and whether it was community health workers, but it's actually healthcare providers within a primary care environment.
Okay, thank you.
Okay, so I have Eva has a question. Are you unmuted, Eva? Okay, Suzanne Brundage.
Yes, hi, can you hear me?
Yep.
Okay, great. Thank you, Jean, for that great presentation. I have a question about the provider screening data and whether we're able to see screens that are taking place, postpartum screening rates in pediatrics settings specifically, whether we've taken a look at whether those rates have increased after billing guidance changes, you know, the CMS clarification that maternal depression screening can be billed to the child's Medicaid code. And I'm also wondering, you know, if that's possible, whether we can track the impact of the dyadic therapy guidance change when that eventually gets rolled out, whether that would have a positive impact on the number of pediatricians that are screening.
Yeah, thanks, Suzanne. Yeah, no, I think that would be a great opportunity with the dyadic therapy. That's one thing, but I don't think it's in place yet. But the other question around the screening, the rates that I was given, which aren't public yet, but I, was speaking with Lindsay Kogan in our department about them, did look after the Medicaid update where it could be delivered by either the prenatal care provider or the pediatrician, and they can sort those out. So we should be able to get those data going forward. And I think that is going to be really interesting to track.
Great, thank you.
Yeah.
Okay, I have Liz Isaacson. You have a question? Did I unmute you? You should be. Liz, I'm trying to unmute you. It's not. All right. Liz, can you hear? Can you? All right.
Liz was just indicating that she dialed in and
Oh,
maybe
maybe that's what.
and then, so we have a couple, I don't know if you can see the chat, Bridget, but there's a couple other individuals who are having trouble speaking. So Donna Bradbury indicated that Amy Jones wasn't here for this call, but to comment on impact, but we can forward questions to her and she'll make sure we get connected with her for those answers. So we will do that. And then I think this is Eve, is unmuted, but no one can hear her. And her question was around a lot of the data that's being captured and discussed as output data. What resources do we have to obtain outcome data? And one of the providers, one of the speakers mentioned some of this at the local provider level. And then she wanted to know who was on the call as well. But I think that's a great point about outcome data, and all the measurement has been focused on processes across a lot of different focus areas in the past, but everybody's moving towards outcomes. So I think that's really valid. We do have at the local level some of the PHQ-9 scores indicating remission and response that are being collected in various programs. And then the other thing I think we can look at is receipt of care through visits, at least in Medicaid, and then hospitalizations or ED visits as a negative kind of outcome for women with depression as well. But I think going forward, that's where a lot of the emphasis is going to be, and I agree. Some of these local initiatives are going to inform us with how to go about that in the future, I think.
Liz Isaacson, you should be unmuted now.
She's asking her question, the chat box does. So.
Oh, there we go. Okay. Sorry, Liz. It says you're unmuted, so I don't know why you're not. Why we can't hear you.
Her question. She did type in her question.
Okay.
So I just wanted to. I can read it because I can see it. It's. I want to build on Eve's question too. We have found in our community that we can get to the screen, but what care does mom get? Or more importantly, what care does mom want? That's a good point. Sometimes it's not necessarily reimbursable by Medicaid, and that's absolutely true. We're so limited by these Medicaid data, but hopefully we'll get some improvement with Spark, with the all-payer database going forward. But this is just reinforcing that we need to focus more on women in care outcomes as well. Thank you for that.
If there's any other questions, we can, folks might want to raise their hand. I'm trying to unmute, unmute folks. I really appreciate you all sort of bearing with us today. I will be taking the class on how to do the webinar tomorrow, and we'll be a little better shape the next time we use this program. We literally just changed a week ago, so we're still practicing here. But I'm happy if somebody wants to put their hand up to unmute you and have you join the conversation or ask a question. So I'm going to leave you. I know that sometimes when you start a project or you're listening to this, especially with we're talking about data, since it's pretty heavy topic for most people to look at. We are going to try to share the slides as quickly as possible so that you can look at the data and the metrics that Jean presented and sort of digest them a little bit. In the meantime, you can feel free to give me a call or an email at any time, and we'll try to field questions as they come in, and also to keep people posted on additional work that this group is going to do. Or if you have any other ideas of things that you think we might want to be doing as we look at data, we're really going to be interested in that. We want to make sure that as we move the project forward, we're coming up with information that's going to be usable for your project, for your community out there. And we will, like I said, try to get this. I did record this, so when we get the ability to do this hopefully soon, we'll be sending out a recording of this as well for folks. I do see Suzanne has another question. Do we have any standardized data on prevention efforts? I'm not sure.
Yeah, I could not find any data on that, Suzanne. That's a good thought.
Yeah. All right, so I don't see any other questions that have come up. So you know how to get a hold of me, and we appreciate you joining us today, and we will keep you posted not only on the project, but on this data work as it moves forward. I know that there's going to be other opportunities for you to weigh in on this and other aspects of the project in the near future. So we'll keep you posted. And if you have anybody else you'd like to add to our list of people who received the emails, please use my email on here to send that along to me. And please feel free to forward any information you receive or any invitations you receive to anyone in your network as well. We want to share this as widely as possible. So thank you very much for your time today, and thank you very much for bearing with us. We appreciate your participation and your interest in this project. Thanks very much.
Thanks, Bridget.
Thank you. Bye-bye.
Bye.